Opportunity as a child to talk about your feelings, express them, and have them valued. So think about ask yourself, why would you go to this person and not that person? Think about in your personal life, who would you go to if you were upset, and who would you not go to if you were upset? How did it make you feel about your emotions when you went to your parent and they said whatever they said? Would they make you feel your emotions are a burden? So, for example, some parents might say, well, look, I have so many other problems, I can't deal with your emotions. Would they tell you that you should be ashamed, that you're acting like a big baby, that big boys don't cry, make you feel ashamed that you are afraid, that you're sad, that make you feel that you don't have a right to those emotions? You know, one patient said that her mother, who was a pediatrician, said, you have nothing to feel sad about or upset about. Think about the children that I work with in my practice who are really sick. You know, you don't have their problems. Think about that. So the child growing up begins developing a schema about their emotion, that my emotions are a burden to other people, I'm going to be shamed and humiliated, that no one's going to listen to me, that my emotions are stupid. That's a very difficult set of thoughts to have about the way you feel. Because your feelings, especially if you're a child, your feelings are such a core thing about you. So these might be, Judy, these might be core beliefs about emotion. Look at that little boy crying. What do you want to do? You want to tell him you have nothing to cry about? You know, I remember a patient of mine who a man in his mid-30s who was a partner in a law firm who came back into therapy after being out for 2 years, single man. And he said, I don't know why I'm feeling down. There's nothing really bad happening in my life. I have a good job, I make good money. I don't know why I feel sad. And I said, who needs you? Who needs you? And he just started crying. And he said, nobody needs me. I've designed my life to be totally independent so that nobody needs me and I don't need anybody else. One of the reasons that some people don't kill themselves is they feel somebody needs me. So I think maybe a fundamental part of being human is feeling needed. It could be your pet. Maybe your cat or your dog needs you. But you're going to think that I need it. I have to get up and I have to take care of them. I have to take care of my children. I have to take care of my wife or my husband or my elderly parent. That people need me. And it's not a bad thing to need to be needed. It used to be popular talking about codependency. The codependency is I don't need anybody. You know, I don't need people to need me. That's not how humans are designed. Humans evolved to live in small groups, 50 to 100 people, who are connected to people every single day of their lives. To be ostracized would be to die. And so in some more traditional cultures, where people not only have a partner, but have children and have grandparents and have aunts and uncles and have a large family that they see on a regular basis, they're constantly connected with the emotions of other people. My mother was Italian. Her parents were from Italy, and my grandmother lived in a neighborhood in New Haven, Connecticut that was all Italian, and people speaking Italian all the time. And every day there were people coming in and out of my grandparents' house. My uncles, who were grown and have their own children, would come home every day for lunch, the three of them, and my grandmother would make lunch for them. It was good. This was like having an great Italian restaurant right there. In fact, my fear as a child was to go to the home of somebody who was not Italian and have to eat their food. So, feeling connected emotionally to other people is important. You can see this little boy, and he's crying out. He's looking at somebody crying out. And you wonder who he's looking at. Is he looking at his mother or his father? Would he feel somewhat comforted if somebody held him and kissed him and told him, I'm here for you? If somebody created a safe place for his emotions, a place where he could, experience that. You think about what therapy is. I think people come to therapy for two reasons, and they're different reasons. One is to be put back together, but the other is to have a place where they can fall apart. To be put back together or fall apart. Maybe this child wants a place right now where he can fall apart and be held. He can fall into somebody's arms and be loved. So some parents are dismissive. They'll say, and they may say something that they intend to be comforting, like it'll work out, you'll get over it. But that's dismissive. That's like saying your experience right now is something that's basically get over it. Or they'll be disapproving, critical and over control of the child's feelings, like stop feeling that way, you're acting like a baby. Or the mother could be, or the father could be dysregulated, overwhelmed with their own emotions. An alternative is what Gottman and others called emotional coaching, which sounds like Carl Rogers. Tell me how you feel. I'm here for you. I want to hear more. It sounds like you're having this feeling and that feeling. Validating, expanding, maybe problem solving. Children who have parents who do more of the emotional coaching are less likely to be anxious, more likely to be able to regulate their own emotions, and more likely to be popular with their peers. On the other hand, they could have a partner who tells them to get over it. This is a typical image of husband and wife, where the wife is crying, and the wife says, oh, what can I do? She's upset about something. And the husband's response is, you can stop crying. How is she going to feel in that scene? Stop crying. I remember sitting in a waiting room of a therapist in New York who was a cognitive behavior therapist, and I heard her on the phone talking to a patient. And the patient was crying, and she said, stop crying, get a hold of yourself. How does that make the patient feel about the pain that they experience? So their emotional schemas and beliefs about their emotion that come from childhood. Like, my emotions don't make sense. I'm weak and childish if I have these feelings. No one understands me. We did a multiple regression on different beliefs about emotion for people with borderline personality, and the highest prediction was feeling invalidated. My emotions are a burden to other people don't feel this way. Imagine if you thought that the feelings you have are feelings that almost nobody else ever feels. You're kind of an emotional, defective freak. No one cares about my emotions. I don't have a right to these feelings. Patients will often say, don't I have a right to my feeling? They've been told they don't have a right to that feeling. Think about that. It's like you don't have a right to be who you are. You don't have a right to your experience. I'll be punished for my feelings. I should stop feeling this way. My emotions disgust other people. I had a patient who had a history of anorexia and bulimia and alcohol abuse, and she described her mother when she was growing up. And her mother, when they would get into an argument, the little girl would run upstairs away from her mother, and her mother would say, "Oh, come down, Judy, come down, I'm sorry." And then the little girl would come down hesitantly, go to the mother, and the mother would slap her. So emotions in childhood are about the fundamental basis of trust. Can I trust other people with emotions? And can I trust my own emotions? Those are beliefs that are very profound, I think, in therapy. So how does fear of emotion affect psychotherapy or psychopathology? Well, one is the fear of shame, the shame in sharing the feelings. So a patient comes in, you're a total stranger, and they're sharing their depression and sadness and anger and jealousy and envy. And their belief might be that people are going to humiliate me. Or a fear of allowing myself to let things happen. If I let myself feel things, I'll go out of control. If I start crying, I'll never stop crying. Or the shame and fear of crying, that crying is weakness and people will humiliate me. If I start crying, I'll never stop crying. The fear of arousing painful emotion when trying new behavior. So the emotion that anxiety will devastate me. So anxiety is dangerous. I might go crazy. Or feeling defective for feeling emotions. My emotions are disgusting to other people. These are the feelings and thoughts a lot of our patients have. That their emotions are a sign of being inferior. I have a patient who's schizophrenic, and he's been in remission for 15 years. He hasn't had any psychotic behavior episodes in 15 years. He's been working full-time for about 12 years. He has friends. And he says that he was thinking about getting intimately involved with this woman that he's been friends with. And he says that, yeah, but my experience is different from I'm not like other people. My experience is different. I'm schizophrenic. I said, okay, so let's think about emotions. Which emotions do your friend, the woman that you're interested in, who happens, to be a very challenging and complicated person. So and the emotions other people have, with sadness, anger, jealousy, curiosity, happiness, excitement, and all that. And which of these emotions do you have? Of course, they were all of them. But he was identifying with the diagnosis, I am a schizophrenic, as opposed to I am a human being with all of the emotions that other people have, who's had some episodes of delusions. But I'm not a different category of a human being. I was talking with a colleague from Turkey, a psychiatrist who's an expert in bipolar disorder, and he was describing how some patients with bipolar disorder think, I've got to be very careful about feeling too good or feeling too sad because I might shift. They become afraid of their emotion variation. And they become anxious about that, which adds to their stress. So thinking about the fear of emotion, how does this play out in eating disorders? A patient with bulimia might be afraid of the anxiety or the feeling of emptiness and sadness that she has, and so they might try to stuff the food in and then throw it out to get rid of all those feelings. Substance abuse, our research shows that people with substance abuse have very negative beliefs about emotion, that they don't feel validated. In fact, a very common belief among people with substance abuse is that nobody understands my feelings, and I'm all alone. My feelings don't make sense, and which may be why AA and other kinds of group formats might be helpful to people with substance abuse. And the fear of emotion and social anxiety and panic disorder, OCD, my anxiety is going to go through the roof. The fear of intimacy, like I don't want to get hurt. If I fall in love, I might get hurt. And what would be the worst thing about getting hurt? People look at you, what would be the worst thing about getting hurt? Getting hurt would be the worst thing about getting hurt. What's going to happen next? How many of you have been hurt in a relationship? Almost all of us. And you might get hurt again. But you get over the hurt feeling, and then you have to think about, well, do you want to be involved in life, or do you want to avoid ever getting hurt? I think that loving somebody means that sometimes you have to accept getting hurt. Being intimate means that sometimes you have to experience being disappointed or disappointing somebody else. So what are emotional schemas? This is a schematic that I give to patients that outlines some of the models of what we're doing. So somebody going through a breakup might feel anxious and sad and angry, but then they may normalize that these emotions are emotions that you have in a breakup. So they then accept it. I can accept I have these emotions. I don't like them right now, but I accept them. I can express them. I can get validation from my friend. I can link my emotions to my needs. I want to be close to somebody. I value intimacy. They can learn. That kind of person never comes to therapy because they don't need therapy. They have a friend. They're able to relate and accept those emotions. But other people have a very negative view of their emotions. So they may feel guilty. They may think other people don't have these feelings. They may have a belief they should only feel one way. They may believe their emotions are incomprehensible, don't make sense. They can't accept the emotion. They think they should always be rational. So they view emotions as problematic. So they can't tolerate the sadness, they can't accept it, they can't accept the ambivalence, and they think they have to avoid the emotion by drinking, binging, doing other things, because they believe that their emotions are going to go out of control and last forever. And they ruminate and worry and so forth. So this model is that people have negative interpretations of emotion, and they have problematic strategies that follow from those interpretations. So think about, like, in your life, if somebody in your family died, you would feel sad. Would you think it's incomprehensible why you feel sad? Would you think that your sadness is going to go on forever? Would you think you should not feel sad? Would you want to be the kind of person who doesn't feel sad? So we normalize certain emotions and then we pathologize other emotions. And a lot of it has to do with how we've learned about emotion. So you can start with a sad mood, and then you can be confused about it, and then believe you're helpless, you can't do anything about it, and interpret the sadness in a bad way. It's bad to be sad. I shouldn't feel sad. You can think that the emotion's going to last for a long time. It's going to be overwhelming. You'll lose control. Believe it's going to escalate. You'll feel hopeless, and then you might start avoiding and isolating yourself, that will be your strategy, avoidance and isolation. But that's going to lead to more sadness. So these negative interpretations lead to more sadness. They perpetuate the pathology. Alternatively, you have a sad mood, but you normalize it, you get validation, or you validate yourself. So these are the things that we can do as therapists, is normalize the sadness, validate it, make sense of the emotion. You feel sad because you've lost somebody, you've lost a relationship. Help the patient recognize that the sadness might be temporary, although we don't know right now. But right now it's real and it feels like it'll be forever. We might think about accepting the sadness or the anger. You might think about, well, maybe there's some things that you can do. Maybe you can engage in problem solving or cognitive restructuring, or you can improve the moment, or you can distract. These are strategies that I mentioned earlier. They all work. But these strategies then will lead to modifying the mood. So having an interpretation of the emotion that normalizes it and recognizes that maybe it's a universal response, or maybe it's related to your values, might help the patient cope with the emotion better. I also think about the patient's theory of change. So all of us have a theory about how to change the emotion. You might think, well, the way to change my emotion is to think about things differently, or to use mindfulness, or to engage in behavior, or get social support. What is the patient's theory of change? So when you feel sad, what do you want to do next? Some of our patients have overgeneralized think, I want to change my entire life. You can't do that. But if that's how they think, they're going to feel more helpless about their emotion. Some may view their emotion as fixed. I'm a sad person, or I'm an angry person, as opposed to I grow and I change. Some may think the way to change my emotion is to understand the past and to complain about how my mother treated me, which then feeds into rumination. Some may believe my sadness is due to biological imbalance, so I have to wait for the medication to take effect. Or maybe it's genetic and there's nothing that can be done, so I'm hopeless. What is the patient's theory of change? When I have an emotion, what do I think is the cause of the emotion? And what do I think would be a way of changing it? I sat in Adrian Wells's workshop yesterday, and there's a lot of overlap with Adrian's model of when you have an intrusive, worried thought, what do you do next? Or the person might think that what has to change is somebody in my life, that my husband has to change, or my wife has to change, or the world has to change. So what do they think about their emotions? What do our patients think about their emotions? So just briefly, if anybody wants slides, I can send you the slides. The email is on the last slide. So we can assess the patient's emotional schemas using a scale that I've developed, 28 questions. And this is the scale. And I'll go through some of the 14 dimensions to give you an idea. Invalidation. Others understand and accept my feelings. No one really cares about my feelings. Think about yourself. Does somebody care about your feelings? Incomprehensibility. There are things about myself that I just don't understand. Guilt. Some feelings are wrong to have. A simplistic view. I like being absolutely definite about the way I feel about someone else or about myself. The idea I'd have one emotion, liking them or not liking them. Or values, personal values. There are higher values I aspire to. So if you miss your partner, is it because you're a loving partner? Or is it because you're a neurotic? So if you think, oh, I miss my partner because I'm a loving partner, then you won't feel so bad. You won't feel bad about feeling bad. You still feel bad, but you won't add on to the rumination about what is wrong with me that I miss my partner. You know? Or loss of control, I won't be able to control my feelings. That's the biggest predictor of anxiety in our studies. Or numbness, I often feel numb emotionally, like I have no feelings. Or overly rational, I think it's important to be rational and logical in almost everything. Is love rational? Is a sense of awe rational? Is appreciation rational? Is curiosity rational? They're not irrational, they're non-rational. They're ways of experiencing the world. Or duration. I sometimes fear if I allowed myself to have a strong feeling, it would not go away. Or low consensus. I often think I respond with feelings that others would not have. Or non-acceptance feelings that have to guard against having feelings. Or rumination. I often say to myself, what's wrong with me? Or low expression. I can't express my feelings with other people. Or blame. If other people changed, I would feel a lot better. So you have beliefs about evaluating an emotion, beliefs about the cause of emotion, beliefs about the duration of emotion, about the universality of emotion, and then a few problematic strategies such as blaming and ruminating. Give that questionnaire to your patients and see what they say. I use this in intakes, and I'll look at this and sometimes go, if I see that some items, some questions are scored in the extreme, like 4, 5 or 6, I'll ask the patient, which emotion do you think other people don't have? Which emotion don't you understand? Which emotion will go on forever? So if you believe that your emotions will not go on forever, that other people have them, and that they do make sense, and they are related to your values, you're not as likely to have rumination and worry and substance abuse and a lot of the other problems that we have. And these emotional schemas are highly correlated with the personality disorders as well. Interestingly, that patients who score high on dependent personality and avoidant personality and borderline personality have very negative views of their emotion. It's not surprising. What's interesting is that patients who score high on narcissistic or histrionic have overly positive views of their emotion. They love their emotions, and they think everybody else should love their emotions. Right? And it's interesting, actually, narcissists surround themselves with people who validate them, like Donald Trump. So, the way that our patients and the way we think about the emotions are going to affect what we do next. And we'll talk about that after the break. So we'll take a break now. No, I'm sorry, we take a break at 3. Oh, okay, good, because I have a lot of slides. I'm glad I have a lot of slides. All right, so what we've gone over so far, we've gone over what emotions are, and, the multifaceted emotions, or cognitive appraisal, intention, goals, arousal, behavior, interpersonal. If you were to think about a lot of what we're talking about as kind of a way of thinking about emotional intelligence. How many of you have heard about emotional intelligence? Think about emotional intelligence as the awareness and ability to differentiate your emotions and strategies to deal with your emotions, how to relate to the emotions of other people, how to deal with your own emotions, when to display emotions, how to display emotions. But this questionnaire is, sorry? Sorry? It's coffee break time.
Yeah,
Oh, I thought it was at 3.
No.
Oh, it's not. Oh, okay. The coffee break time is now. Okay. So we have coffee break.